This is a meeting with Jessica Martinez reviewing her measures worksheet, and her charter is due Sunday. Okay, here we are, Jess.
Okay. So we were talking about the tools and measurements.
Right. And do you want to share that so you can ask me questions?
Oh, sure. Hold on.
So it's the green box with the little white arrow.
Hold on. Just I shrank that.
Oh, no worries.
Shrunk you. Okay.
I shrunk, huh?
Yeah, he shrunk. Okay. Sure. Okay. I'm gonna make this bigger so you can actually see it. Okay. So I feel like the first half of it was okay.
Hey, Jess, I can't see that.
We can't. Oh,
it's black. I mean, there's writing on it, but it's really hard to see.
I can't see either, and I don't know how to change it on my computer. This computer is really weird.
Okay, that's a little better.
Okay, wait, maybe I'll move it into like a doc. I'll like copy and paste it. For some reason on this computer it does that, and I've just been like suffering through it. Okay, let me put it on. Sorry. Okay, cool. Yeah, I feel like the first half of it was okay, and then I started kind of, I guess, getting lost as the project went on. So for the processes and everything, some of them were like pretty wordy. Let me go back to like the original doc, which I have here.
The simpler you make your measures worksheet in terms of conciseness, the easier it's going to be. You get lost in the words.
Okay.
So you have a screening tool, right?
Yes.
The number of patients on whom screening tool was used. Just put number of tools utilized.
Okay.
So you're correct. It's just too much. Number of screening tool, choreo screening tools used. Right?
Yeah. Instead of like
over the total number of patients seen, which means that you're going to be screening every patient. Is that correct?
Yes.
So every patient, every single patient on labor, or every patient who's laboring, or do you need to define that? I don't know who's on your labor floor, so it's up to you.
It would be like everyone that comes through triage, which is everybody.
So every admitted laboring patient?
Well, I'm even doing like when I go through and look through the chart, I'm starting to do it on just people I'm seeing for labor checks who may go home. Or
Okay. So you're going to do it on everybody, and that's perfectly fine. I just wanted to clarify it.
Okay.
And then sometimes what happens, especially the first cycle, the first 2 weeks, you realize, oh, that person's here for a C-section. I don't need to, I'm going to exclude all planned C-sections, right?
Oh, yeah. I guess I don't see them anyway.
So you can start thinking, that first cycle really is when you will decide if this is appropriate or there are people that you shouldn't have in there or whatever. Okay.
So can I just do patients for the CNM group since I'm not doing like preterm?
Yep. Okay. Identify. Now, the only thing I'll say to you though is, do you want to put that in there? Because don't you hope that eventually this spreads to everybody who's laboring, even the doc patients, even though they may never do it? I mean, do you need to limit your definition, even though you in principle may only be using the midwifery patients?
Eventually I would like it to disseminate to everybody, kind of like we do for the postpartum hemorrhage.
Yeah. So I would just have total number of patients seen.
Okay.
You're going to decide who's going to start this.
Okay. I just like for this project, I wanted to focus on like term choreo instead of preterm because it's such a larger.
Yes, that's fine. So then it's total number of term patients seen.
Okay.
Right?
Yeah.
That doesn't limit it to your group, but it limits it to the term people. That's what you're working with right now.
Yeah. Okay.
Okay. Identify admitted patients who have, I'm not sure I agree with that, but we can think about it. Okay. That could always be how you spread it. If it goes super well, you could always spread it to, now I'm going to spread this to the preterm because they're the people who really need it, right?
Yeah. But I thought like if there are like modifiable risk factors maybe and like the ones that we are giving choreo to. Yeah.
Okay. Identify admitted patients who have risk factors for choreo over the number of people screened. Correct. Okay. So that is good.
Okay. And for this percentage, like when I guess I was kind of confused because when we had talked about it before, it was like the baseline was how many people we had seen that we were giving choreo, which was 30%.
Right, but that's the number that you're identifying, right? It's
Yeah.
not the number who you're screening.
Oh, okay. Yeah.
So it's correct. It's just your identification, not your screen, because you aren't using a tool right now.
Yeah. Okay. Okay.
So just put that into your outcome baseline.
Oh, okay. Okay.
Does that make sense?
No,
not your goal, your outcome baseline.
Okay.
There you go.
And then the outcome goal.
Now you're going to have to think of a goal.
Oh.
Now your goal, I know that's that is your national rate, right?
Yeah, but we probably aren't going to reduce it by 26%.
Right. So you might want to put your goal at like 20%. I mean, that would be huge if you could get down to 20.
Yeah.
Okay. So now you have a tool, and this is going to be, so let's change it from toolkit to, how about just calling it the Right Care Bundle so that you know what your goal is here.
Okay.
And this may be another checklist. I don't know. That's up to you.
Okay.
So you have a toolkit, right? Or you have a tool.
Yes.
So how do you get a process definition for a tool?
How many people the tool is being used on over the.
Remember, it's not the number of people.
How many times the tool is being used?
Yes, the number of times, the number of tools used over. Now you have to decide what the denominator is.
Okay.
So let me just tell you that your denominator is wrong.
Okay, so would it just be like the total number of term patients seen again?
So let's think about this. Your toolkit, your bundle
Mm-hmm.
Tell me what's going to be in it, roughly.
The toolkit would be leaving bag of waters intact, reconsidering internal monitors, reducing vaginal exams.
So it's a list of things.
Yeah.
And a list is also called a checklist.
Oh, okay.
Right? So this could be Right Care Bundle checklist. Yep. So it's the number of tools used, and you're going to fix that to say the number of checklist, Right Care Bundle checklist, or whatever you're going to call it. You can think of your name. It's the number of tools used. So if patients are going to get this done, don't do this, do this. Who are the people who are going to get this done to? Is it going to be the high risk folks, or the preterm laborers, or everybody, or who's it going to be?
I mean, I feel like it's right care for everybody.
So just put it's going to be your same one.
Total number of term patients.
Number of people. Identify patients who have at risk factors. So you're going to do this for, let's just think about this. You're going to do this for everyone, not those who are screened. I agree with you though. Total number of term patients. Admitted, are these admitted people?
Oh, yeah.
Yeah, same with your other one.
Oh, okay. Because I'm actually screening even people like when I'm
those are not necessarily admitted, right?
Yeah, because if they're at 3 centimeters,
yeah,
go home because I talk to them about choreo risk factors and stuff.
Okay, so you've got your screening on everybody, on term patients, number of term patients, but not admitted, and then you're identifying the number of people screened. Okay, and your tool, your Right Care, is going to be the number of Right Care Bundle checklists used over the total number of term patients, because you're only doing these. The Right Care is only going to be the people who are admitted.
Yeah. Okay.
And so if you use this checklist, what is your outcome if you use the checklist?
The outcome would be the number of patients who the Right Care Bundle was used on over the number of patients with risk factors. Is that wrong? So
if 10 people have risk factors and you use it on 5, that's 5 out of 10.
Yes.
Think about this. Do you want to know use is what? When we use something, is that a process or an outcome?
It's process.
Right. So the outcome is different. What are you hoping? Sometimes, I mean, it can be confusing, right? Because you want to get the tool completed, but the goal isn't really to complete the tool. What is the goal here?
The goal is to utilize Right Care on the people who are at risk.
Okay. On everybody, you said.
Oh, okay. Yeah. On everyone. That's true.
So if you're going to be using Right Care, let's think about this. We've got 5 things on the checklist. And patient 1 gets 4 things used. Patient 2 gets 3 things used. Patient 3 gets 5. So we've got 3, 4, and 5. I got a 3, you got a 4, somebody else got a 5 out of the 5 things that are on the checklist. How are you going to measure that? What could you use?
Like average number of
Average score, just average, plain old average score of the checklist. Because that's going to give you a score. It's not going to say how much of the tool was done. I mean, it is, but it's giving you a score. We got an 80% today. We got a 50% today. We got to do better. We're not doing good. And then what you have is, you know how on the case management log, it had like on the top number of patient, on the left is going to be patient 1. On the top is going to be number of vaginal exams, number of IUPCs, number of internal leads, number of AROMs, blah, blah, blah.
Mm-hmm.
Pericare, epidural waited until 6 centimeters or whatever, whatever your list of right care stuff is going to be along the top. And then you've got all your patients along the left-hand side. So you can see out of the 5 patients we're here, we got a 3, a 2, and a 6 on our vaginal exams. Mm-hmm. So for a 3, a 2, and a 6 is 5, and 6 is 11 divided by 3 is about just under 4 each. Hey, we're meeting that, right? Mm-hmm. So that way you can look at each one of those columns and see how, when you look at all your patients for today, you were there 7 to 7 last night. So when you look at all your patients from last night, I saw 5 patients, and this is how we did on those 5 patients.
Oh, okay. And then each one, like, it wouldn't necessarily be one.
So it's going to be, it's not a numerator denominator. Remember, an average score means that you took all the scores, you added them up and divided by however many there were. Okay. That's the definition of an average score.
And then, but with that, it would be, would I do the average score of toolkits used? Or
no, it's not utilization. It's just the average. You're going to make a checklist that is scoreable.
Yeah. And then, but we have like different categories, right? It's like, so we met it on SVEs, but we didn't meet it on.
Yeah. And so that's where you'll break it down. When you get to next term, you're going to do what's called aggregate data. And you're going to have all of those little columns. This section had 4 columns. This section had 3 columns, et cetera. And you can think about making that, like, this section's going to be pink and it's going to be all the vaginal exams, IUPCs, internals. This section's going to be green. It's whatever other things that you're going to, waiting on the epidural, getting them up, pericare, whatever else you're going to do. Mm-hmm. And then you can give an average score of each individual column. You can give an average score of each section, and then you'll have an average score of the overall tool.
Oh, okay.
So you'll be able to collect some really cool data. Yeah. Now, what are you going to put for your baseline here? You have baseline on some of this. So you have baseline on the average number of vaginal exams, for example, and the average number of AROMs. So you can just put in there vaginal exams, average 3.4 over a birth. Average AROMs, X% of people. Average epidurals, X% of people.
Okay. And then, so it wouldn't be total number of people with risk factors.
You've got, and you can look and see, Jess, if you use, say, 5 things, right, or 5 categories, and you have baseline on all 5 of those, which you're going to try to get right now, you could just put all of those things averaged together are 64% instead of listing them all out separately. But sometimes you have more things on your toolkit, on your bundle, than you're actually doing.
Oh, okay.
Does that make sense, Jess?
So if I have more things on there, then I don't know how to.
So that's why sometimes I think you have baseline on most of it, don't you?
Yeah.
So I would just take an average percentage of all those things. Like if your goal is for vaginal exams and the average is 5.2, make that a percentage. So everything becomes a percentage, and now take the average percentage of that whole bunch, and that's going to be your baseline.
Oh, okay.
Are you sure that makes sense?
The average percentage of the whole bunch of what I'm using.
All your little interventions.
Okay. So like if 75% of people are getting epidurals before 6 centimeters, but we're doing less than 4 exams on like 25% of them, just the average of those 2.
Yep. Okay. Yep. So that's not going to go here in outcome. It's going to be under your baseline. Yeah, right there.
Okay.
So just put average of the bundle, whatever that happens to be. And if you've got 90% of that bundle you have baseline on, just state that as the bundle.
Oh, okay.
Instead of each separate one. Sometimes you might have 10 things in your bundle, but you've only got baseline on 2 of them. So that's why you would put the 2 in there. But if you've got most of which I think you do, you don't need to write them all out.
Oh.
You will have that in your brain, and you will have that somewhere. so that you can always say to somebody, hey, our baseline on this was this, our baseline on this was this, but you're not going to write it on your measures worksheet.
Okay.
Okay, so every tool, tell me the operation and definition of every tool.
The operational definition, you mean like the process over outcome, or?
The operational definition is the mathematical equation, like how I'm actually physically going to count this.
So how many, I'm physically going to count how many tools are used over the amount of, the total of patients?
Yep. So it's whatever the appropriate people are.
Okay.
So yes, it's the number of tools utilized for every tool. In order to get there, right, you got to use the tool. So the process is always using the tool.
Okay.
And then the outcome is whatever, that's going to be different for every tool because every tool has a different goal.
Okay.
Okay. So so you've got now your process, you've got your screening, and you've got your bundle. And I want to make sure that you understand that bundle. So we'll come back to that one.
Okay.
Now this is your patient engagement tool. This one you were struggling with. The tool was kind of questionable. What are you doing here?
Trying to educate people on how they're, like, when they're in labor, the different risk factors that they have and how we should be caring for them in each risk factor and what they should be self-advocating for.
Okay.
And it was kind of ugly, but I'm not really good with computer graphic stuff.
Let's see it.
Okay. So I just wanted to give them one piece of paper that discussed with them, or that let them know what they could do to reduce their risks.
Okay, so I love the look of this. What is the reading level of your people?
I feel like overall they have a pretty good. I have only come across two completely illiterate patients, out of probably 400.
Okay.
And they have a pretty good level of comprehension.
Okay. So let's look at this. Try laboring at home for as long as possible. What does that mean to somebody who's this, your first baby, you're panicked.
Yeah.
Your partner's panicked. Let's go to the hospital right away.
Yeah.
Do you have to give them a resource somewhere to say, go look at these things? Or do you have to give them something or a website that they can look at? I mean, just sending them home saying, try labor at home as long as possible. How realistic is that?
Not really. I mean, obviously when I actually see them and they're in early labor, I have a long discussion with them about other things to look for and coping strategies.
But remember, this is not for you.
Mm-hmm.
This is for the patients and every patient who comes in.
Yeah.
You're going to start with you. But now Judy Butler's working for you today. I don't know anything about your project. I'm willing to do anything you tell me. Try laboring at home. I've been a hospital midwife for 50 years. Not really, but I'm saying that. And I don't know what people do at home. I only know epidurals.
Okay.
So I don't know what to tell them.
Oh, okay.
So you have to think about, this is a tool that your patients are going to use. So what knowledge do they have? If you're going to give them some generalized knowledge, give them a place to go to look. Look at this site for home comfort measures. Go to this link on your home computer. Go to, whatever.
Okay.
All right. Keep your perineum, the area between the genitals and rectum, clean. That's pretty. Rely on visual signs of labor progress instead of cervical exams. Are they going to know what that means? Your patients?
No.
No. So that's for your nurses.
Yeah.
That's not anything that your patients are going to know. They're not.
I'm talking about vaginal bleeding and rectal pressure and things like that.
Okay.
Yeah.
So again, you've got to look at this tool, and I would talk to your husband and say, hey, what does that mean to you?
Okay.
Well, he can cheat a little because he's lived with a midwife for a while.
Yeah.
My husband calls himself a lay midwife.
Yeah.
But you are giving this to patients.
Yeah.
You have to assume that they know nothing.
Yeah. And like some, maybe like 25 to 30% have attended the birth class.
Right.
For birth
So
class.
that's not very much.
Yeah.
So you have to think about, excuse me, I'm eating my breakfast. These have to be short. It's colorful. I love it. But it has to be short. And you either have to point them in a direction, go look here, or here's a handout. Which one of these are you interested in? Do you have questions about laboring at home? Here's a handout for you on laboring at home.
Oh, okay.
So the patient can say, I don't know how to do that one.
Mm-hmm.
I want to do that one, but I'm like birth plan. Who does that with me?
Yeah.
I'm 38 weeks. Right?
Yeah. And we have like a kind of generic check.
Okay. So if you have a generic birth plan, then that's something, again, what you're doing now is you're making this really not just patient lack of knowledge, but you're giving them a choice, which is even higher, right?
Mm-hmm.
This is a better shared decision-making tool because you're saying, which one do you want to talk about today? And do you need further resources on these things? Let's go over some of these and let's give you further resources. And then you have a little, folder or something on the floor that has a slot for each one of these. Here's some information on this. Here's some information on this.
And that's something that, like, I don't have to create necessarily like the, links for laboring at home, but I can like take it from a website, right? Okay.
Yep. As long as you give them credit.
Okay. And then like say, see this or whatever can I reference a handout that I could easily have printed out in?
Well, how you've got to make this easy for your patient who thinks she's in labor, who has a 5th grade education.
Okay.
So you got to think about that. The other thing that I'm going to say to you is now you have to make it measurable. So you've given patients a choice. They can either check it, circle it, whatever, but somehow you've got to measure, it was given to them, not just given to them, but used. So you collect them. Mm-hmm. If you collect them, you always have, the question is always, could I use a dot phrase? Because the patient might want to keep this, right? Mm-hmm. It might be helpful for them to keep this. So maybe you don't want to collect it, but you want to use a dot phrase, shared decision-making tool utilized.
Oh, okay.
And then your measurement is going into the charts and saying how many of these tools are utilized.
Okay.
But I want you to make this bi-directional. I don't want it to be a handout. Which ones are you interested in? That's one option. Check it off, circle it, whatever you want to do. And then your dot phrase is the tool was utilized and chose this one, and this one, whatever. You have to make it measurable.
Oh, okay. So not just how many people used it, but how many people used it and like which aspects of it were they most utilizing?
Of course, because if you think about the data that you're collecting, everybody wanted information on laboring at home. So now that information could be, 9 out of my 10 patients wanted more information on laboring at home. And they thought that this tool that I gave them was not helpful. So that leads you to the next act of saying, hey, I gotta spiff up my resources to give them because this is what people really want.
Okay.
So you're being led by your data. So
how I can improve it. Okay.
Each one of these things has to be information that a patient can use. So I'd be very careful about a link because they may not have the link.
Okay. But I can even put something at the bottom of like their, what do you call that? Their printout at the end, whatever it's called right now.
The ABS.
Yes.
Yep. You could put it in there.
Okay.
You could have the handouts come from, if you have resources at the hospital that are part of patient education, you know how you can hook that to the ABS? Mm-hmm. So you could look at what you're telling them and see if those are in your educational resources at the hospital already. Oh, it may not be wonderful, but they're easily accessible. Then you can work on getting them better.
Oh, okay.
So this form has to be bi-directional, meaning it has to be something that I can't just hand you as the provider and say, hey, do this. Mm-hmm. You do this, I do this. You tell me you want to know about laboring at home. I have a handout that I've reviewed with you, and I'm going to write in my chart, shared decision-making tool utilized, laboring, and you could even number them all and say, Patient interested in number 1, reviewed handout.
And then use that for all of them. Some of them like just walk and keep moving. I mean,
Yeah, you don't need anything for that. That's self-explanatory.
Yeah. So like that wouldn't necessarily be scored as.
No, it could certainly be scored. So you have to think about this. The process is what? You have a tool. What is the process?
The process is how many times the tool is being used over how many people I gave it to be utilized for.
And you got to specify that. Who are those group of people? Now, how are you going to measure that it was used? Are you going to collect them? Are you going to have a dot phrase? What are you going to do to collect this data? I'm telling you that you've got lots, 1, 2, 3, 4, 5, 6, 7, 8 sections here. It might be super interesting for you to have this data. You know, if they circled the try laboring at home and ask your provider about risks and benefits of invasive procedures, I'm not sure I like that one, but you know, then you could collect it and say, well, they circled this one or they checked this one and this one. That's your data. They used the tool, and then the provider would have to say tools utilized, handouts given for number 1 and number 6.
Oh, okay. So then I'd have to number which ones they
Somehow. But what I'm saying to you is you have 8 pieces of information that might be really important to have information on each one of those. Not just that the tool was utilized, not the generic tool was utilized, but these are very interesting little pieces that you have here.
Mm-hmm.
So I think it would be interesting. And then your outcome. So if they use this tool, what's going to happen?
They would tell me things they wanted more information about, and I could either have a handout ready or something to provide them more information.
Right. But what is the outcome? You use the tool, they ask you about it. What's the outcome?
The average.
No, sorry. Don't think about operational definition.
Okay.
I'm simply asking you, I come in labor, you and I work through this tool together.
Mm-hmm.
What is the result of us using this tool together?
Which areas you found most helpful and what things you need more information about?
Okay. And if you give me that information, now what's the outcome?
If it was successful when you used it.
So what does success mean?
That you felt like you had the tools you needed to labor at home and to delay early admission.
Okay. So you're talking, do I feel confident in laboring at home? Do I feel that I have the resources that I need to make decisions? Do I feel that I have the support that I need to make these decisions? Do you see what I'm saying?
And
you're asking the woman to make a decision, I think.
Okay.
You're giving her knowledge. So you're asking her, what do you want to know? Then you're giving her that information and saying, does this help? Was it useful? Do you feel confident? Do you feel you have the tools and the resources to have this, to decrease your risk?
Okay.
Or whatever?
So then I have to measure her level of confidence like after the tool is used.
Mm-hmm. You could do that. Okay. That's one. I just wanted to get you to there. Okay. So now let's talk about how you would do that. You could give her a survey, right? Mm-hmm. Say 1 to 5. Do you feel confident making this decision? Do you feel confident? Strategies for decreasing your. Do you feel confident in your knowledge? Do you feel confident in your skills because you're asking her to do things? Do you feel confident? You know, a bunch of things. Or what is another thing that we could say? What did we just talk about? Use of the tool, bang. But you have all these 8 sections here. You could score them.
Okay. Like, do you feel like you know it, like you have enough information about laboring at home?
Well, that's a survey. Let's look at this tool and think about this. Try laboring at home, keep your perineum clean, rely on visual signs. That one you got to fix.
Yeah.
Use alternative coping strategies. You're going to have to give them information there. Mm-hmm. Ask your provider about risks and benefits of invasive procedures like internal. So you're envisioning this. I don't know how appropriate that is.
Okay.
What do you think about that?
I mean, it's a risk factor, and I guess this is more on the provider and nurse side where we're giving full informed consent and really discussing risks and benefits.
Okay. I mean, that's a good answer.
But it wouldn't really be on. I mean, on the patient's end, like I ideally they would like hold out for risks and benefits in non-emergency situations, especially. But I guess like it would give like a lot of questions that I don't know.
Don't take it out because I'm saying to take it out. I want you to think about it.
Okay.
And I want you to think about what are you really, I mean, maybe you're teaching them how to be advocates for themselves.
Mhm.
So one of the things you want to know is, does this help you to, everyone might not know what the word advocate means. Does this help you to, be your own? You'd have to look at a different way to say that because advocate is a hard word.
Yeah. Could I just say like, discuss risks and benefits of all interventions or?
You could.
Okay.
Well, you got to think about what you want for this tool. Do you want to stick to just people who are coming in labor? And I think you're on a good roll here in terms of, you got to think about what are your goals. You want to keep them home. You want to keep their perineum clean. Rely on visual signs of labor progress instead of, I don't know what that is. I don't know. That makes no sense to me as a patient.
Okay.
What are you trying to get to with that one?
So when I tell people like, oh, you're in early labor now, signs of progress would be a bloody show, if your contractions increase in strength, intensity, and frequency.
So what are you trying to get to?
List that. I'm trying to like show or tell them or make them understand signs of labor progress.
Why?
So that they're reassured that their contractions are going from early or turning from early labor to potentially active labor, or at least
Why are you doing that?
to reduce cervical exams and early admission.
There you go.
Okay.
So that's what you're getting at. So don't beat around the bush.
Oh, okay.
So you, thinking about what you're trying to tell them, there are other signs of labor besides vaginal exams, or limit your vaginal exams and ask your provider or nurse or somebody, why they think you're farther along or less far. You know what I mean?
Mm-hmm.
But you got to keep this from the patient perspective.
Oh, okay.
They don't know, for the most part, when a vaginal exam should be done, why it should be done or not. I think what you're getting at is the vaginal exams. Do you need it or do you not?
Yeah.
So understand when a vaginal exam is really needed. Maybe that's the question.
Oh, okay.
I don't know. You've got to play with these and you've got to really think about them. I would take this into one of your patients who's in early labor who got admitted with an epidural or not, or, she's got her epidural and she's up sitting chatting.
Mm-hmm.
And I would show it to her and say, what do you think of this?
Okay.
And have her give you her comments.
Okay. And
so
see how readable it is. Okay.
You have the use of the tool and you have to think about, how am I going to measure that? Yes, the operational definition is utilization of the tool, but how am I going to know if the tool is used? Is it going to be in the chart as documentation? Is it going to be, I'm going to collect all these and they're going to be circled or checked or something? How am I going to know it was utilized? But that is the correct operational definition for the process.
Just like, how do I ensure that? Or
how are you going to know that? How are you physically going to count them? When Judy Butler's covering for you tonight, I want to do this for you. What the heck do I do?
Okay. So
then you've also got to figure out what it is you're trying to measure. Are you asking them to make a decision? There's lots of things on patients' ability to make a decision, lots of evaluative. Or do you want to just say they circled 2 or 3? Is that going to tell you something? So you have to ask yourself, the outcome should give you some information so that you know how to make the tool better.
Okay.
So if you're asking yourself, maybe if you're asking yourself, how can I make this tool better? You're hoping to empower the patient. You're hoping to engage the patient. So those are things when I think about the outcomes, I think, okay, Did this help you make a decision? Did this help you stand up for yourself? Did this help you, 1 to 5, so that you have some, were these understandable? Were they helpful areas that you found useful? You know what I mean?
Yeah. And some of them, like, they might need more or less information about.
Yeah. And so we could still do the thing where you talked about,
Mhm.
okay, she's interested in number 1 and number 4. Here is my folder that everyone on the floor has access to. Here's answers on question number 1. That way you're standardizing. That's a term you want to learn.
Okay.
Because you have to understand that I don't have your knowledge. And you don't have Joe Smith's knowledge.
Mhm.
So when I come in or Joe Smith comes in, you want us all saying the same thing. So if you have a handout for each one of these, I have something and Joe Smith has something that we can look at and go over with the patient, and relatively we're going to be all talking the same thing.
And it's all like in the same place, really
Uh-huh.
easily accessible to everybody. Okay.
Yep.
So any midwife can use it, not just.
Make it easy.
Okay.
So I think you're looking at empowerment and usefulness, and maybe you even ask them in the survey which one was most useful, which one was difficult to understand, because that's definitely going to give you information that's going to help you adjust the tool and make it better and better and better.
Okay.
There's lots of ways to do that, Jess. That's why you have to really think about, why am I doing this tool? What is my purpose?
I mean, it is to educate and empower them, and I go through so much of it when I triage people about signs of labor. So I guess I just have to like figure out exactly what I'm saying and.
Oh, and I think you're also trying to help them avoid getting these risk factors. Did this help you? I don't know. You just have to think about it. Keep it simple. No more than 5 questions.
Okay. Okay.
And then how will you measure that? If you had a survey of 5 questions, how will you measure that?
I mean, would it be a survey like completely disagree, neutral?
That's up to you.
Okay.
But how will you measure it? How did you measure your team survey?
I did like a Likert scale.
And how did you measure it? How did you come up with the data point that you said, this is my team percentage?
How many people actually filled it out?
So if 5 people fill out the tool and I got a 5 and you got a 4 and somebody else gets a 3, how do you come up with the
average of it?
Yeah.
Oh, okay.
The average score?
Okay.
And are you going to get more information from a Likert scale or a yes or no?
A Likert scale.
There you go.
Okay.
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 Did that help?
Yeah, I think so. I need to simplify this
Mm-hmm.
quite a bit for it.
And you literally have to have it ready as if tomorrow you're going to walk in on the floor and you're going to have all this ready to go.
Okay.
That's your goal. Not that I'm going to do it over the break or next week. Like when you submit it, it should be, this is good to go.
Okay. Okay.
All right. So we did your first 2, I think. Let's go back to your measures worksheet.
Okay.
So we did your right care. We did your patient engagement. The only one left is, and you time of, so you're okay with how to measure the patient engagement tool?
Yeah, the outcome is like still, I'm trying to like think of how exactly I can measure that.
Well, and that's something that I think you have to think about. You're exactly right, because you have to think about what, sometimes an outcome is the average score of the tool. They use 2 out of the 8 things.
Mm-hmm.
However, you always have to ask yourself, when you get into next term, what you're going to be doing is that outcome needs to inform you. It needs to give you information that can better the tool and the whole goal of it. So if the goal is to empower the patients, you need to ask questions about empowerment. So when they tell you, no, the tool doesn't empower me, you can then go back and say to the literature and say, okay, what does empowerment mean? And what is some evidence for how we empower patients? And I'm going to incorporate that into my tool. And then you use the tool again and you say, did that empower you?
Okay, and then just keep working on it until they're like, yes, I felt empowered. And
Right. And now you say, okay, I think that question is good. Now I'm going to ask them about did the tool increase their knowledge? Did they feel they had the right resources? Did they, what you have to look at the individual tool in order to know and really ask yourself, why am I using this tool? What is my hope? I hope that they use the tool, but that's the process. What am I trying to get at? Why do I give a darn if they use this tool? And your questions want to be in there enough so that it can say to you, oh, they don't like this piece, or this isn't helping them, or whatever. And then you go change the tool.
Okay.
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 And that's all your outcomes for everything. Okay. Now the team engagement is that team engagement plan. And we're giving everybody partial credit on this because we have created a team engagement plan for you. And if you listen to Dr. Myers and Dr. Jollis's video, again, Dr. Myers' video is on the team engagement plan itself, how to use it, how to think about it. And then Dr. Jollis's video is how to actually measure it.
So my baby just figured out how to open a door. So I don't know how that happened. But Danny, the baby just opened the door. Oh, I don't know. Here, I'm on the. Very proud of herself.
No worries.
I have no idea how she did that.
She's a smart little one.
Yeah.
Okay. So the team engagement plan is all made for you. You have to fill in, I'm going to do 5 huddles. My plan is to do 5 huddles, a team QI meeting every 2 weeks, a dashboard with, information that's updated every 4 days. You get to pick and choose.
Okay.
Go in and find that the template is in the course. And like I started to tell you that we're giving everybody partial credit for this because the teaching is a little bit ahead of you.
Okay.
So that's why you haven't got it. Your tool is going to be that team engagement plan. It's in the course, all made for you.
Okay, and I just choose what I think would be most effective on my.
Nope, you're not using you're going to pick how many huddles you're going to do, how many meetings you're going to do, and be creative. So you're going to be judged on how creative, how diligent, like how frequently you're going to be doing these things, because the best practice tells us that if we meet with our team frequently, keep it in their face in different formats, emails, posters, meetings, huddles, all of these different things, that it's going to get us there a little bit more. What kind of engaging activities are you doing with your team? So what I said is Dr. Myers and Dr. Jollis's video will go over how to use the tool and how to measure the tool.
Okay.
And that's in module 2, and I believe it's step 2 and step 4.
Okay. I'll go over that again, so I don't have to like recreate the wheel. No,
it's different than last term.
Oh, did it not? Did my balancing measure not show up on yours? Because I saw.
So I see those 3 things underneath there. Is that the balancing measures?
No, it's not. It was I got deleted or something. It was like something about how choreo, reducing the number of SVEs over increasing labor time, or overall labor time or something. I'm kind of bummed because I saw it at 0 and I was like 0, like I mean like.
Okay, so explain to me what a balancing measure is.
It's how you're like changing care over how it's adversely affecting.
Don't tell me the measurement. Tell me actually, what does it mean to have a balancing measure?
When you change something to try to improve it, the ways that it might make a different aspect of the care less effective or.
Yeah. Perfect. So if you think of the old-fashioned scale, if I fix choreo, what's going to get bad? What could be wrong, right?
Yeah. So and I couldn't think of anything specifically like if I fix choreo, I mean there'd be like no downside, but it would be like my goal is to reduce SVEs, and in that way I might be prolonging overall labor curves. Would that be something? Or sorry.
So if you decrease the number of vaginal exams, you could be increasing the labor curve because people might not get PIT started early enough or something.
Yeah.
I mean, that's the right idea.
Oh, okay.
So maybe it's the length of labors is your balancing measure.
Okay, that's what I had. I don't know why it was deleted, and that's why I wanted to ask how I got 0. But now I'm seeing that there was nothing in
Yeah.
that box, so that makes sense.
So maybe length of labor in minutes.
Oh, okay.
That's it. That's all it is. You're going to look at what is my average length of labor, and now you're going to look at, am I above that or below that?
Okay.
So it's simple.
So like being less aggressive with augmentation could be because we're not like I'm having them do less vaginal exams, so they don't know. Okay.
So if you're looking at length of labor, you could, on the same aspect, you could use, less Pitocin, although I'm not sure how that's a downside, but less Pitocin or less augmentation. Maybe you're looking at all methods of augmentation, but you have to have a baseline. You have to say our baseline is here, and I think length of labor is really your key.
Okay.
Our length of labor average is X number of minutes, and I don't want it to go over that by more than 5% or something.
Oh, okay. And
the other things aren't really, I mean, the world would not be a worse place if we didn't use more Pitocin.
Yeah. Okay. I'm bummed at myself that it got deleted, but I mean, it's one, I guess.
Well, the good news is it's an easy point, right?
Yeah.
Okay, Jess, did that help? What questions do you have left?
I feel like the tools and measures part was the part I was most struggling with for the upcoming assignment, but that I might like eat my words on.
Well, it is the part that has to be right.
Yeah.
And the good news is that you have this draft to submit. You'll get comments again, and you'll have 2 weeks, and then you'll get to have another chance before your final. So, I mean, that's why we built all these pieces into it. You actually literally get your touch point, your tools and measures, your draft, 3 tries before you get that 4th one.
Okay. To really tweak it.
Yep. So make sure that you look at, for the charter, make sure you're looking at the sentence limit. Make sure that it makes sense. You're writing in complete sentences. This is writing, okay? Not the measures. The measures is not sentences. But the rest of the charter is actual written sentences that make sense, that have a verb and a noun and all that good stuff. That's part of the doctoral level. So you don't want to lose points in silly places. So make sure you're looking at the rubric. It's all there. You should have all this data. You've done your chart audit. That's your problem, right?
Yeah.
You know your national data. You got that. That's the first part. In the bottom half where it talks about it, you're going to say, well, this is how I envision it going. The patient's going to come in. We're going to do the shared decision-making tool. We're going to screen them for risk factor. You're just going to walk me through it. And then barriers. And the barrier section, you give a barrier for each of your tools. The barrier to this tool is this. The barrier to this tool is this. And a barrier is not, remember from your gap analysis, a barrier is not what's wrong with it. A barrier is it's not going to get used because the nurses are not going to use it. Or whoever's not going to use it.
An extra step.
Right. So what are the barriers? Because then what you're doing is you're actually using that and saying, okay, this is a barrier. I got to make sure my tool is put in the right place, that there's plenty of them, that they're easy to use, that they're the right color so everybody sees them. Whatever your barrier is, how am I going to be ready for that? Somebody's pinging me or you?
Probably not me.
Me. It's okay. She can wait a minute. Okay. All right. Any other questions?
No, for the part that's like, how does it fit into your national data and or like costs? It's really hard to there's not a lot of info about like the national cost of choreo because it like
right. But what does choreo do? What happens? What are the downsides of choreo? What happens?
Starting antibiotics, causing dysfunctional labor patterns, increasing C-section rates.
All those things have statistics.
Yeah. Oh, okay.
You can extrapolate it. You can say, we're using 3 doses of antibiotics that increases hospital costs by X%. You can find stuff. You just have to be a little bit creative in your, how do we think about costs? Length of stay is a big one. C-sections, bam, yeah. Look at what you need to look at is, okay, if we have a 30% choreo rate, what's our C-section rate? Now, if your C-section rate's only 10%,
it's not.
Yeah. You know what I mean? You know what I mean, though? You gotta use your brain. We have a 30% choreo rate. We have a 100% epidural rate. That I don't think that you can use, but we have a 30% choreo rate. What are the pieces that fall from that? increased C-sections, possibly baby in NICU, procedures in NICU. You know, NICU has a cost.
Yeah.
Staying an extra day in the hospital has a cost.
Yeah.
Having MFMs have to be involved in your care has a cost.
Okay. Okay. So, you know, just
to extrapolate that.
Okay. Yeah. I guess I just need to learn how to extrapolate, because some of the things, yeah, maybe they can be tied to choreo, but not necessarily like, you know, in the chart or in.
No,
You know,
but national data is not your chart.
yeah.
You know, you can say our C-section rate is, you know, with a national C-section rate of 33% or whatever it is now. I don't know if it's still 33%. Anyway, whatever, or regional or hospital or whatever, you know, we have an X% C-section rate, which is an additional cost of $500 per person. We see 7,000 patients a year. That's a $500 million, you know what I mean?
Yeah.
You can give a case for that in one sentence.
Oh, okay.
Okay. And you can just say that, you know, you're using data from whatever, you know, wherever you're looking at the national C-section rate and how much a C-section generally costs, 5 times higher than a vaginal birth or whatever. You can get that data and you can cite it. You can have a citation here and a citation here, and now you can give the link. You're not saying it caused it. You're not saying it's exactly related, but you're saying they are related. They are associated with each other.
Okay. Okay.
Because you know that choreo affects C-section rates.
Yeah.
What is your C-section rate?
Our C-section rate is, I think, down to 23% right now.
Which is better.
Yeah.
Yeah.
Because it had been, as of 3 years ago, it was 25%. So they've been working hard to reduce it.
Yeah.
But, you know, still not low. It's lower than national average, though.
Yeah. 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 I mean, that's not horrid.
Yeah.
Okay.
Like a lot of like supporting vaginal birth seminars and
Great.
physiological birth things. So that's a lot of my toolkit things were like supporting vaginal birth and things like that, how to get people like up and out of bed.
Right. Well, and so what you're doing is you're aligning your project with what your hospital's been working on.
Okay.
When you present this to your team, you want to use those words.
Okay.
We are using all of the, remember we went to this conference and we went to this conference and we went to this conference. We are using all of that in this project, because if we don't use those things, this is what occurs.
Yeah. And there's like a push for reducing our postpartum hemorrhage rates.
Yep.
So we can kind of link.
Yep. You join all, that's aligning. That's bringing everybody on the same page.
Okay. Okay.
Okay.
All right.
All right. So when you look at that, look at the rubric, look at the assignments on IHI, it goes through the charter, each step of what you have to do. It spells it out really clearly, because I don't want you to lose silly points.
Yeah. Okay.
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 All right, Jess.
Okay. Thanks.
I'll send this to you.
Okay, great. Thank you.
Bye-bye.